Yeah, Assalamu alaikum. Welcome everyone on board. Um so today we will just try to continue what we started in our last discussion. So our last discussion was on a pregnant female for with mitral stenosis for cesarean section. Okay. So today we will just take a pediatric patient, and this will be for some abdominal surgery. Okay. So I will just try to give you an idea that how you should chalk out anesthesia concern or correlate. So first of all, going to the pediatric patient, if you can just think about what can be the abdominal procedures in a pediatric patient, you can say neonate or mm,
Appendicitis,
okay, so appendix is one of them. What else? What else, please?
Sir, laparotomy,
Laparotomy. Okay. Or
maybe due to obstruction, maybe due
obstruction
to
due to rupture.
rupture.
Okay. Um, in a neonate, what can be the abdominal surgeries you can see?
imperforated anus,
Imperforate anus. Okay. What else?
Hirschsprung's disease,
Hirschsprung's disease. Okay.
Pyloric stenosis,
Pyloric IPS, infantile hypertrophic pyloric stenosis, and abdominal wall defects like either omphalocele
omphalocele,
or gastrotritis. Okay. Uh, we just said obstruction, but to be specific, it may be hernia, whether it is obstructed or simple. Okay. Um, some specific procedures in, for example, can we have a cholecystectomy in a child, in a pediatric patient? What will be the patient group who will have appendicectomy? Sorry, cholecystectomy. Can you just mention one of the group, one of the disease group?
biliary sclerosis, primary biliary sclerosis,
Sickle cell disease. These patients have tendency for to have cholecystectomy. Okay. And we missed congenital diaphragmatic hernia. It's considered like in between, it's a thoracic or abdominal. We are just trying to chalk out congenital diaphragmatic hernia or tracheoesophageal fistula because they have different varieties. Okay. Okay. So, yeah, like, if any of the surgery, whatever the surgery you are dealing, there will be one thing which will be the age group related, physiological, pharmacological, and anatomical considerations. Okay. So these things will be in your mind, and other thing will be the procedure which they are doing. And another classification which you will have is whether they are doing it laparoscopic or open. Okay. Lap or open. So this will be a differentiation. Either the surgery will be done laparoscopic or open. This is one thing. Plus, they are doing it as an emergency versus elective. Okay. So the concerns will be, or another, you can say the patient is unstable versus a stable patient. Okay. So just if we Can you hear me? Am I audible to you?
Yes, sir. Yes, sir.
Okay. So if I just focus with reference to stable versus unstable, so what do you think with reference to abdominal surgery? You should be thinking one most important thing is the fluid status. Okay. Because the normally normal patients, we have a tachy like adults or low BP. So here actually these things will not be very reliable, and it is tricky to estimate the fluid status. So how you can assess the dehydration in a pediatric patient? Yes, anyone please? Like mucous membranes, fontanelle, okay, capillary refill,
Skin trigger.
skin, the mucous membranes, and also skin, okay, urine output, uh, conscious level, like too much irritable to obtunded, okay, and of course the primary pathology, whatever is there. So, but usually it will be either in the form of nausea, uh, in the form of either vomiting or diarrhea, the source or obstruction, or in the case of abdominal wall defects, that will be excessive, uh, loss of fluid from there. So this what whenever you are dealing with such case, you should be in your mind that the normal parameters of blood pressure and heart rate will not be telling you good
Sir,
information.
the voice is not it comes obstructed.
I'm sorry. I'm sorry. What did you say? In intestinal obstruction, you have problems in the fluid absorption. So there is dehydration. Okay. We have a lot of GI secretions. Okay. So I'm sorry, I was disconnected. Can all of you hear me now?
Yes, sir. Now you are audible. Before it was not audible. Yes,
Okay.
sir. Now it is good.
So obstruction and the abdominal wall
Sir, kindly
defects.
repeat from conscious level, sir.
Okay. So
Yes, sir.
actually,
Repeat it, sir.
yes, primary pathology will be, just a second. I'm sorry, there is some problem in my connection, or let me change the connection. Okay, can you hear me now?
Yes.
Okay. So actually, I was saying that the normal parameters which we use in adults, some of them will not be very accurate if you are dealing with the pediatric patients. Okay. So primary pathology is very important to know. Usually with the vomiting or diarrhea, and in case of intestinal obstruction, GI secretions, there is a problem with the absorption and the abdominal wall defects. Okay. So if it is more like omphalocele, maybe viscera may be open, so there will be much more loss. Okay. So these are the basic things which you should be knowing. Okay. So that is something before we actually go to. So another thing that if you just think about physiological, pharmacological, and anatomical considerations, that there is a limited reserve, okay, with there will be not much reflexes of the cardiovascular system. The liver is not mature, the kidneys are not mature, and the concentrating ability is not there. So initial doses of medications you need to give more, and the subsequent doses will be reduced. Okay. Anatomical changes with reference to airway. It will be a challenging airway, anterior larynx, easy desaturation. Okay. More oxygen consumption. So these are, I'm just giving you a hint, you can revise it. And the same, as I mentioned, that you should be knowing the change, how it affect anesthesia management, and how to handle the situation, how to manage, as I asked you to do for the pregnant patient. Same you should be using for elderly patient, or even any other case. Try to see whatever disease you are studying. uh, Try to see what is the change, what is the effect, and then how to manage. So in whatever disease you are studying, just try to divide your management or your plan in this way, that what is the change. Like, I'm just giving you example. Patient has muscle problem like myasthenia gravis. So the change is that there is problem with the there is risk of aspiration, there is risk of altered response to the muscle relaxants. Okay. So, because of the disease pathology. So that is the effect. And how will you manage that? You will be trying to avoid the medication, you will try to give aspiration prophylaxis. This is just an example. So whatever disease you are, whatever patient you are dealing, try to uh, tune your brain in objectively. Even whatever you are reading, just try to see and divide it in your anesthesia management steps. Okay. That a pediatric patient, you need to have different sizes blades, different equipments. Another common pediatric challenges. One of them is with reference to consent. One of them is with reference to IV lines. One of them is with reference to preoperative anxiolysis. Okay. And
NPO.
there are NPO. Okay. And so whenever you are dealing with the pediatric patient, all these factors should be in your mind. If you will not have these things in your mind, then you can miss some of the points. So in any pediatric patient, then temperature management is very important, because normally there is shivering mechanism the pediatric patient does not have. They can easily become hypothermic, and their like all system will be in trouble. You will be in trouble post-operatively. So this is another. Then fluid, either you can give less fluid or more fluid very easily. Then blood and blood products. Okay. I'm sorry, say it again. I'm really sorry, I'm not able to listen to you clearly. If you can write in the chat box maybe, or repeat again, please. Okay. So you have to be very careful with the blood loss estimation. It's very critical, because maybe you should be knowing how much is the blood volume, and because it's very sensitive to uh, have proper estimation of blood loss. Okay. So with fluid, actually there was a concept of giving a terrible PEDS solution, which is a killer actually, a hyponatremic. Okay, so it was a hyponatremic solution of this. So it is better to have isotonic fluids, Hartmann's, or normal saline. And for maintenance, you can have D5 dextrose, D5 with half normal saline. Okay. And you have to take care of hypoglycemia. So you can have if you have a patient who can have hypoglycemia, you can give either 5% or 10% separately. And you don't need to like for the replacement, it is better to give isotonic, and for the maintenance, you can use these solutions with the care of the electrolytes and especially blood sugar. Okay. So this will be the common things with reference to pediatric patient. Okay. What other common challenges you can have in a pediatric patient? Just think about it. We discuss about consent, we discuss about IV lines, we discuss about altered their cardiovascular system, like they will not be able to, they have fixed, yes, hypothermia I told, they have fixed cardiac output and heart rate dependent. So heart rate should not decrease, because if heart rate decrease, the cardiac output will not be able to maintain. Okay, so this is another thing. What else? Any other point?
So everything will be difficult. Arterial line, CVP line, monitoring.
Okay, just with reference to arterial line, one point, do you know the concept of this preductal? Anyone? Which arterial, which line will be telling the preductal? It's right radial. And why? Because in cases there is patent ductus arteriosus. So this is aorta and this is pulmonary artery. Okay. So this is PDA. So after this there may be mixing. Okay. So if you want to have a clear one, that will be through the right radial artery, because the right brachiocephalic trunk will be before this ductus arteriosus. Okay, so that's why you need to monitor through right radial artery. Okay, CVP, what will be the problem with CVP, especially with the reference to short neck? If you are taking, and you have to be very careful, there are incidents of like guide wire going inside or puncturing the aorta. Like it is no doubt it is difficult. And even like if you are taking arterial line in adults, maybe ultrasound, you can take help of ultrasound, but in pediatric even it is difficult. Okay, so if you don't have the lines, then you can go for intraosseous route. Okay, uh, I had discussed before intraosseous line in detail. About the site you can find in the folder. Okay, and the pediatric I discussed before. So these are the common things in a pediatric patient going for like for instance, I just discussed about the abdominal surgery, but it can be for example, if you should be knowing the usual pathology. Okay, so if you have a pediatric patient with for example, Down syndrome, 4 years old child with Down syndrome for adenotonsillectomy. Okay, so if you have this case, you have concern with reference to 4 years old child, should be knowing the concern with reference to Down syndrome, and the third is the adenotonsillectomy. So whatever case you are thinking, just try to write radial artery. Yes. Okay. So like if you have a 4-year child, we discussed the physiological, pharmacological, anatomical considerations with more reference to, because this Down syndrome patient, they can have cardiac issues. Okay, they have communication problem. Okay, cardiac issues like AST, VST, endocardial cushion defect, then they have short trachea. They can have hypothyroidism. They can have epilepsy. They have atlantoaxial subluxation. Okay, so these are common things which you can face in patients with Down syndrome. So now each concern will be like if you have patient with epilepsy, so you have to think about the medications the patient is taking, okay? The control and the effect, multisystemic effect of medications. Like these patient have a medication can have effect on bone marrow, liver, okay, kidneys. Okay, so one point will give you a tree so that you have to think about the other things. You have to rule out. And another important thing with epileptic anti-epileptics is the drug levels. Okay, drug levels. Okay, so the anti-epileptic medications, if your patient is similarly, if there is hypothyroid, significant hypothyroidism, you will be thinking like that. Similarly, cardiac issues, you have to rule out significant cardiac involvement. And if it's something need to be done, you have to outweigh risk versus benefit. Because adenotonsillectomy is adenotonsillectomy can be an emergency. Have you heard of kissing tonsils? Because these patient can have the tendency to develop OSA. OSA is not related to only obesity. Okay, in this situation, maybe there is obstruction. So not a real emergency, but you might not, you cannot delay forever. Okay, so like because the purpose of having these case-based discussions is that you need to integrate various systems together. These two cases which we discussed the last time, we discussed about the pregnant patient for mitral stenosis, and today it's actually I have just given you a sniff of whole of the pediatric anesthesia. That's what is pediatric anesthesia. You have to just think about difference which you can face with reference to laryngoscope, endotracheal tubes, IV lines. There is always a debate between cuff versus uncuffed. Okay. So because before the cuff used to be high pressure. So usually we have now low pressure cuffs now. So because it has better seal, so it is better. Now it's like not contraindicated to have cuff endotracheal tubes. Rather, it will have better control of the airway. But with reference
Sir,
to
up to what age we can use comfort, sir? From neonate, we can start this comfort too.
now there is no,
We can use.
that's what I tell you, that there is
Okay.
always a difference between cuff words and uncuffed. I don't do much of neonates, and there is a lot of group of people who will consider it as a problem. Usually because you have to use one size less. Okay, so maybe in some hospitals, not every size cuff, every size endotracheal tube is available with cuff and uncuff. So it's more common to have uncuffed tubes. Otherwise, there is no now, because it depends on the. You just tell me one thing. What will be the problem with the cuff? Can you just explain what is the problem?
Sir,
Yes.
yes, sir. Sir, tracheal mucosa get pressure edema. Sir, airway obstruction. Because
Okay,
already
so
narrow trachea is narrow due to edema, it will get obstructed upon extubation.
no, just now come to what is the narrowest point in the pediatric airway.
Initially, it was cricoid cartilage.
Okay, so
Now,
actually
subglottic.
the
Yes.
tube will go pass and it will stuck. Okay, so sometimes it is difficult to have. With reference to mucosal problem, why we can we monitor the cuff pressures?
Yes, sir. Yes, sir. There are
And how much pressure it should be?
10.
No,
No idea.
actually it is with reference to the hydrostatic pressure, okay?
Yes, sir.
Hydrostatic pressures. So it should be around 25. It should be less than 25 because after that the hydrostatic pressure is around 28. So it should be less than 28. And actually there are cuff manometers, okay,
Mm.
by
Yes,
which we can monitor the cuff pressures. Another thing is
cuff
that the
pressure.
duration, then how much duration. There is no, actually this is a gray area of anesthesia. Like I tell you, another debate. A lot of people don't use muscle relaxant.
Yes.
Okay. So what do you think? Is it a problem in using muscle relaxant in pediatric patient? If you have a ASA1 pediatric patient, is there any problem?
Mm. Maybe receptors. No. No idea.
Actually, like for example, if you are talking about suxamethonium, okay,
Yes, sir.
someone can
Hyperkalemia can occur.
no, in a normal patient. We use suxamethonium, a lot of people use it. Okay.
So they say in neonates there's an extra junctional actually acetylcholine receptors, and once success is active, it releases a lot of this not potassium.
So
Matlab,
there are more
on
chances of
Morgan it is
bradycardia.
written.
More,
Yes, sir. Morgan.
I don't, I have no idea about it. I don't have very good relationship. I divorced Morgan after failing a lot of times. So I have
Yes,
very
sir.
bad relationship with Morgan. So I'm sorry, I cannot comment on
Yes,
Morgan.
sir. Actually,
I
in
don't
Morgan it is
remember
written
you.
if you have a cardiac arrest after giving scoline, so you treat hyperkalemia.
Anyways,
It is
the thing
written
is
there.
that is
Okay,
something
sir.
else. Actually, I tell you something. There is no clear.
Okay, sir.
There is. I'm talking about a pure ASA1 baby. Okay. Versus, for
Okay,
example,
sir.
if you have a premature baby, or if for example, you can defend it that you should not use muscle relaxant. For example, if you have a syndromic patient, okay, if there is a syndromic patient, then you can say that maybe there is some involvement of the neuromuscular system. Then you can say, okay, if you are getting the intubating conditions without muscle relaxant, there is no problem. Okay. So actually, yeah, if you are talking about endotracheal intubation, maybe I can say that we can skip. But if you are using supraglottic, I have serious objection, because supraglottic airway devices and you are not given muscle relaxant, there is high chance of laryngospasm. Okay. So I don't have the clear data about it, but practically it's a disaster. Never use a supraglottic airway device without muscle relaxant for a surgery with a exception. Exception is, for example, MRI. Okay.
Yes, sir. In herniatomy also they can not use. In hernia,
No,
herniatomy
actually,
or
no
undecided
hernia. That is the hernia. The
intestines.
reason is something else. Okay, because in these surgeries there may be delay, there may be delayed gastric emptying because some involvement of the gastrointestinal system. Okay, and another thing is that these days they are using laparoscopic. So in laparoscopic surgery, supraglottic airway device. By the way, people are using it. I don't know what's the advantage you are getting by have a constant palpitation to you. There is not much of advantage if you are using supraglottic airway devices for laparoscopic surgery. People use it. I cannot. I will never accept this change because you cannot defend the things. Okay, but it is said that if you have a pressure in supraglottic airway devices, if you have like 15 for the normal this LMAs and 20 for iGel. Okay, so if you have airway pressures less than that, you can use it. But I don't think so. It's a very good idea because airway is not secure, and especially if you have not used muscle relaxant, so there will be chances of laryngospasm. So again, this may be a debatable issue, but it's not very safe. Okay. Then another thing,
Sir,
actually,
it
I
will be
missed.
better. Sir, it will be better in situations where there is emergency and neonate or pediatric patient having cough upper respiratory tract infection. In that, supraglottic device is good choice.
Okay, so upper respiratory tract infection.
Yes, sir.
So there are already more secretions, and there is already some more edema. So you will put a supraglottic airway device to have chances of more obstruction. No?
Then a patient with cough, secretions in the airway.
So there is more chance of laryngospasm.
So if we
Anyways,
will not interrupt
this is
the
a debatable.
airway,
This
yes,
is a
sir, it is
debatable.
debatable.
Actually, this is a debatable issue, but yeah, actually it depends on the scenario. Okay, but the bottom line is that if you are using supraglottic airway device without muscle relaxant, there will be chances of laryngospasm. Then another thing that you should be using some anti-sialogogue. Okay, like you should use glycopyrrolate or atropine. Okay, so I can understand your point, that your point is that the patient has reactive airway and you are just trying to avoid intubation. It makes sense. But again, why you are doing any surgery at that time? So it should be an
Emergency
emergency
surgery, sir, emergency. In
emergency
emergency,
surgery.
we can.
So in emergency
Yes.
surgery, do you have clear NPO?
So
So you
not
would like to,
necessary.
so emergency patient is always considered as full stomach. Okay.
Okay, sir.
So how will you defend? It's difficult to defend. Practically, if you do, again, I tell you something, a number of things
So it's
which we
difficult
do.
to defend you, sir.
Yes, then it will be difficult for you to defend yourself. Okay, so that's the problem. That
Okay.
NPO issue will come. So practically, whatever you do, I'm not sure about it. That in which in emergency surgery you would like to have LMA. In case in that sad case, you can give some steroid. You can give nebulization post-operatively. Rather than trying to just and another problem, I
So
tell you
there was
something.
one patient I had, sir. I'm sharing with you. There
Hmm.
was patient of pediatric airway, reactive airway, in which there was obstruction in the renal system, and they want to do in emergency. And I under that patient with the uh, supraglottic device LMA.
Okay. So was it a quick procedure?
It takes 15 to 20 minutes, but patient had severe cough, and it was postponed by me in the same list 5 to 6 times. But they want to do in emergency. That's why I did it with high risk consent.
Okay. Anyways, actually, again, I tell you something. There are something. Practical conduct of anesthesia is different. I will again say that if you are using LMA, your airway is not secure. So with LMA, if you don't have a good seal and you are ventilating, not ventilating in a good airway pressures, then the chances of complication will increase. That's what I want to say. So try to it's you have to be more careful with LMA than endotracheal tube in pediatric patient, because I have seen at least two, 3 times in my career very terrible complications with LMA. Okay, if the depth of anesthesia suddenly decrease, you are not able to maintain the depth of anesthesia, because with reference to MAC, actually in young child the MAC is increased or decreased.
So child MAC is decreased.
No, it is increased.
Is increased in neonates.
Okay, so there is more requirement of anesthesia. Sometimes they even the initial dose in requirement of a lot of medication you need to give more. Okay, so that's why the only point which I wanted to highlight is this thing. Okay, that you have to be
Sir, I
very
had
careful.
this patient given an anesthesia with all your concern with our patient was deep enough, and I was giving propofol and all these things before
Or you know
anything.
how another thing, if you want to be very meticulous, you have to monitor this. Okay, so that at any time you are 100% sure that depth of anesthesia is not decreased. Sorry,
Yes,
if,
sir.
depth so okay, so you can monitor it up to 40 to 50. if you want to be sure. There are so many ways to defend your answer. Okay, but you should be knowing. If you don't know what you are telling, how will you manage? Okay.
Okay, sir. Okay, sir.
So just to have a summary that we discuss a pediatric. Actually, I have discussed this topic a number of times before. So it's a repetition. I will share this recording as well as the previous discussions. But the bottom line in is that try to integrate the case scenarios. Okay, how to assess airway in neonates and infants, sir. This is a very difficult question even for me. Can anyone tell how to do it? Yes, you have to answer yourself, Sumera. It's a very
Okay.
difficult. It's
Sir,
a very
as the
difficult.
MPS cannot be assessed, sir, it is well just by physical appearances.
Actually, this is only you always. There are two things. Okay, one thing is anticipated difficult airway. Okay, so
Yes,
the answer is that because you cannot do the malam patti even. You can just
yes, sir.
see the externally, and even they will not tell you much because there will be always be short chin. The numbers, the distances are not accurate. So actually, there
Yes.
is no clear idea about assessing the airway. Yes, if you have some syndrome, you will anticipate even
Hmm.
more. So
Anticipation.
you
Yes.
should have
Thank
you should have all the difficult airway gadgets.
you.
Okay.
Yes, yes, yes. Thank you, sir.
So by the way, just what can be the things included in a difficult airway trolley? Yes, please.
Stylish,
Okay. What else?
all tube sizes,
Okay. What else?
Different blades,
Very good.
video
Different
laryngoscopy,
video laryngoscope. Okay. What else? What will you do in Kiku?
bag mask,
Kiku
no.
cannot
Patient is
intubate,
not.
cannot ventilate.
Good. So
Sir,
cricothyroidotomy,
LMA, sir, LMA.
or,
Can go to-
or
LMA,
ENT
tracheostomy.
surgeon,
ENT, like even not even if it is ENT surgeon is not there, at least I have just asked this question suddenly, and such question can be
So,
asked in any exam, which you are not
so we can
expecting.
pass cannula, sir.
So it is cricothyrotomy. Okay. So
Yes,
cricothyrotomy for
sir.
cannot intubate, cannot ventilate scenario. Even if you don't know, you don't need to show it to them, but you have to tell cricothyrotomy. But are the landmarks very clear in pediatric patient?
No, sir.
No, sir. No, sir. It will be very difficult. Okay.
So actually it's a very challenging scenario. This is actually pediatric update. So I think I will share it today, inshallah. So
Sir,
even I
cannot
have
we
not.
LMA in can't ventilate, can't intubate situation?
That will that you will I will tell you something that cannot intubate, cannot ventilate scenario will be labeled when you are even not able to ventilate with the LMA.
Okay, sir.
Okay. So cannot intubate, cannot ventilate scenario is that you are not able to ventilate, you are not able to
Sir,
intubate.
what is the incidence of Kiko in neonates and pediatric age group? I think it is very less.
I cannot have, I don't have the number, but uh, like it's a disaster because if you have this scenario in front of you, the baby, you will lose the baby because maybe adults will have more time. The causes of cardiac arrest is more respiratory in pediatric and elder in adult it is more of uh,
Cardiac.
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 Okay, so in pediatric, the if for example if sudden hypoxia occur, so it is better to give because next maybe you will have a cardiac arrest. So before the patient goes in bradycardia, you should do something. Okay, So like that's why it's like it's a dangerous scenario. Okay. So okay. So actually, I will share this to you, and the basic mechanism we have already discussed. Pediatric analgesia, we can discuss that paracetamol we can give, NSAIDs. It's a like again a debatable thing. Some people uh, use it, some people don't use it. Okay, because up to 1 year the kidney functions are not normal. Okay, uh, so I'm just passing through anything. Hypertrophic pyloric stenosis. It's some of them are medical emergency and some of them are surgical emergency. So hypertrophic pyloric stenosis is a medical emergency. Okay. So you have to treat the, what is the pathology here?
Electrolyte,
Hypochloremic, hypokalemic,
metabolic,
hyponatremic,
metabolic.
Metabolic
metabolic alkalosis with
alcohol.
paradoxical aciduria. Okay. There is paradoxical, there is already alkalosis, but there is a paradoxical aciduria because potassium is so low that it is not compatible to life. So just to conserve potassium, the kidneys excrete hydrogen
Protein.
to
Yes.
to save potassium. This is the reason of
Paradoxical aciduria.
paradoxical aciduria. Okay. So actually they can ask you this question. That's what actually I was trying to discuss with you people. Cold periphery depressed fontanelle oliguria hypotension. I will suggest all of you to have a look at this update. This is the latest 2023. Even we have 2024 update in anesthesia, pediatric anesthesia. Sorry, update in anesthesia. Every year they take a separate topic, and usually there are some specific additions, like this 37 number is especially for pediatric anesthesia. Okay, there was before, I think few years ago, 7-8 years ago, there was another specific this one. So these are actually some of the advantage will be that you will have specific surgeries for pediatric patient, like some of them we already discussed. So we have VP shunt procedures. Uh, any surgery can occur in any age group, but some of them, like with reference to Wilms tumor, okay, this is more common in pediatric patients. Then, as I told you, that in sicklers, there are more chances of intestinal laparotomy as well as cholecystectomy. Cerebral palsy. Cerebral palsy patient which come for which procedure? Yes. Cerebral palsy patient can come for which procedure? Any procedure can come, but actually sometimes they are coming for feeding the tubes. Okay. Because they usually they have bedridden. Yes, any procedure I can come, but with reference to any patient bedridden with pneumonias, so sometimes they are not able to take food. Okay, so this is one of them. Yes, dental procedure also because of poor hygiene. Okay. Okay. Pediatric neuraxial anesthesia. Unfortunately, I have limited knowledge on pediatric neuralgia. Any one of you do pediatric spinals? I never did it in my career. Actually, in Saudi Arabia, there one of the drawbacks is that some of the subspecialties, if you don't have any certificate, you cannot do. Like in our hospital, pediatric anesthesia is being done by a specific pediatric anesthetist. Though I have done a lot of pediatric anesthesia, but as a protocol, I cannot conduct pediatric anesthesia. The very specific procedures, it's a domain of people who have done some fellowships in pediatric anesthesia. This is unfortunate. I really, really want to do, but in our hospital, we are not able to do it. Okay, so thanks a lot, all of you. So we will.
Sir, how we classify the ASA classification in pediatric patients?
Yeah, I don't think so. ASA has done something specific for pediatrics. The same thing. If you don't have any medical disease, it will be ASA 1. If we have a controlled, that just like same we do in adults. And actually there is a lot of, like for example, you have asked this question. Just tell me one thing. What about cancer? Which ASA it should be? Carcinoma.
ASA 2 or 3. ASA 2 or 3.
If it is not affecting any organ system, should you say ASA 2?
No, it will be ASA 1.
So actually there is a lot of gray area. Okay. So my suggestion that there are so many things which are not covered by the societies actually. You have actually asked a very good question. I will try to discuss this question with some of pediatric anesthetists, and I will come back. Okay. So anyways, thanks a lot, all of you, for attending and giving me honors. All of you are welcome anytime to ask any question. And if you want to learn more, you have to ask questions anywhere or to anyone around you. Okay. So the more you will ask, the more you will learn. This is what I can suggest to all of you. Okay, my dear. Thanks a lot, all of you, for joining. Jazakallah khair. Assalamu alaikum.
وعليكم السلام ورحمة الله.